Good afternoon. Welcome to the 2012 Everett v. Fox Student Case Competition Finals Round. My name is Breon Simmons, and I will serve as your moderator. Please take a moment to silence all cell phones and communication devices. Before we begin, we're going to allow the teams to introduce themselves, as well as introduce our judges. A few reminders: you all will have 20 minutes to present your case, followed by a 10-minute Q&A session. Once we begin, please, sorry, a little nervous.
You're telling me.
When you're ready to begin, please let the timekeeper know that you're ready to begin. You will receive a 5-minute warning towards the end of your 20 minutes, as well as a 2-minute warning. Additionally, for the viewers in the room, once we begin the presentation, there will be no entry or exit into the room. Please go ahead now and introduce yourselves, followed by our judges.
All right. Hello, everyone. We are Team C, and my name is Amy White.
I'm Xavier Robinson.
And I'm Amasa Baldwin.
Good. It's still morning. Good morning. I'm Jennifer Campbell Fitzgerald.
Good morning, Denise Brooks Williams.
Hi, Pam Sutton Wallace, Duke University Hospital.
Dale Oliver, HCA Healthcare.
Pastor Herb Buchanan.
Yvonne Spence, Dignity Health.
All right.
And Ken Page, Catholic Health Partners.
All right. Great. Thank you.
Thank you. Please signal to the timekeeper when you're ready to begin.
All right. Well, good evening, everyone. We are the Strategic and Healthcare Transformation Team, part of Mercy Health System. And my name is Amy White, and today I am here with my colleagues, Amasa Baldwin and Xavier Robinson. Team C is ready to begin. We have been tasked with creating a care coordination model for Mercy Health System. This care coordination model will cater to the dual-eligible population in Northwestern Ohio. We will walk you through the situational analysis, the organizational structure, the operational plan, and the financial impact of PARADE, which is our care coordination model. PARADE's main function is to cater to the dual-eligible population and coordinate their care in Northwestern Ohio, because currently the system is broken. Dual eligibles are in the middle of a convoluted and fragmented process of coordinating their own care. They need to ensure that they create their appointments with their primary care physicians, their specialists, and they also have to arrange for transportation to get them from point A to point B and back home. Additionally, they have to ensure that Medicare and Medicaid are paying for the services that are being rendered. For someone who is medically compromised, this can pose as a huge struggle. There are roughly 10,000 dual eligibles in Northwestern Ohio. And these dual eligibles experience a number of chronic conditions, with depression being the #1 condition at 42%. 50% of dual eligibles experience at least one chronic condition, and astonishingly, 1 in every 4 experiences 5 or more of these chronic conditions. In addition, dual eligibles experience several barriers, and they can be at the patient level, the system level, or at the provider level. A patient-level barrier could be the dual eligible's health belief system. A system-level barrier could be that the facility that they need to travel to is too far for them. And a provider-level barrier could be a language challenge between the provider and the dual eligible. We are certain that PARADE will address all of these barriers. In 2011, 4 of our hospitals in the Northwest region received roughly $44 million for the care of these dual eligibles. We spent roughly $42 million providing these services, which left us with an excess revenue of around $2 million. Now, although we had $2 million in excess revenues, the outcomes of our dual eligible population are not improving. And the fragmentation of care that they're receiving is leading to Mercy Health System waste. Now, we know for certain that our excess revenues will diminish when the dual eligible population increases and the reimbursements from Medicare and Medicaid for fragmented costs decrease. This will all negatively impact Mercy Health System, which is why managing costs to this dual eligible population is crucial. Now, Ohio is also experiencing challenges with the catering of this population. Currently, Out of all of the state of Ohio's Medicaid enrollees, 14% of them are classified as a dual eligible. And this 14% is spending roughly 40% of the state of Ohio's total Medicaid budget. Now, Ohio realizes that there is a disproportionate spending on dual eligibles. Now, Ohio's solution is the Integrated Care Delivery System, also known as the ICDS. And this ICDS is Ohio's solution to the fragmented costs, or the fragmented care, and the high costs of this population. Now, the ICDS is a 3-year demonstration that will begin April of 2013, and it aims to improve access to care and long-term services for all dual eligibles. Now, we as Mercy Health System are faced with the challenge. How are we going to efficiently and effectively partner with Ohio's ICDS demonstration? And ladies and gentlemen, the answer to that is PARADE. PARADE stands for the Partners for the Advancement of Dual Eligibles. And PARADE works with the Ohio ICDS components as a nonprofit accountable care organization. PARADE caters to dual eligibles, coordinates their care, and wants all dual eligibles to advance their health. Now, our mission is simple. We want to be a partnership of community-focused healthcare organizations that provide high-quality, comprehensive, coordinated healthcare. Our vision is to be the #1 healthcare provider for all of Ohio's dual-eligible population. And our values mirror those of Mercy Health System and include compassion, excellence, and service. Now, so what is PARADE? Well, PARADE is a nonprofit accountable care organization that currently works with all of the Northwestern Ohio Mercy Health System hospitals that can be seen in the outlined box. We also have clinical partnerships with patient-centered medical homes, long-term care services, behavioral health centers, and physician group practices. PARADE, coupled with these clinical partnerships and our 4 existing Mercy Health System hospitals, will work together to coordinate care for this delicate population. PARADE also has 3 key stakeholder groups, and these groups are the community, the providers, and the payers. So in order for PARADE to fully function, we need the help of additional staff members. Our staff members that are currently in Mercy Health System need to learn our vision and our mission behind this delicate population. And for that reason, we have outlined them in blue, and these staff members will be trained by PARADE to understand the mission and the vision of our organization. Also, we will need to hire additional staff members, and they could be outlined in red. These staff members will also cater to the coordination of all dual eligibles. Now, to explain a little bit about how PARADE is actually going to function and work for our population, I'll hand it over to Xavier, who will talk to you about the operational plan.
Thank you, Amy. Good morning, everyone. We are confident that PARADE is the solution to addressing the challenges facing dual eligibles in Northwest Ohio, because PARADE works with each individual dual eligible to ensure that their care is streamlined across the health and social services continuum. Specifically, we make sure that dual eligibles receive the right care at the right place at the right time. We do this by coordinating care, by putting our nurse case managers into the care facility environment. We make sure that proper care plans are developed and executed. These nurse case managers are supported by a cadre of community health workers, which facilitate treatment, make sure our dual eligibles get from appointment to appointment. We also recruit and retain members. We motivate our provider network. We manage our partner stakeholders. And we also distribute shared savings to Mercy's health system and to our physicians and across the provider network. Now, we've taken all of the services that dual eligibles need to maintain their health, and we've broken them down into these 6 categories. And I'm going to talk to you a little bit about how PARADE interacts with each of these categories. If my grandmother were dual eligible in Northwest Ohio, I would want her to be a member of PARADE. This is because PARADE would give her one-card access to all the health services that she needs to maintain her wellness. So instead of having a card for Medicaid and a card for Medicare, she'd be able to take that one card to her service provider. They'd be able to look at her health record, understand her unique needs, and coordinate care. I know that my grandmother would benefit from high-quality, affordable primary care service delivered via our network of 4 patient-centered medical homes. We propose that PARADE partner with 2 existing PCMHs already existing in the community via the local federally qualified community health center, the Neighborhood Health Alliance. We also propose that Mercy create 2 additional PCMHs using our existing physician practice group assets. We know that primary care is so important because it's our best defense at keeping people out of the acute care setting. We also propose partnering with behavioral health organizations to offer preventative care to our dual eligibles. This is so important because, as Amy mentioned, 42% of dual eligibles in Northwest Ohio have a documented diagnosis of depression. We are certain that this will drive down costs because by offering that preventative behavioral services, we're going to keep people out of the emergency room. And this is so important because nationally, 1 in 8 visits to the emergency room have some behavioral health underpinning. We're also going to partner with social services because we know as health services executives that there are a number of things that impact the health and wellness of our dual eligibles that take place outside of the delivery treatment facilities. And so to address these social determinants of health, we've partnered with Catholic Charities, which will connect our dual eligibles to various public assistance as needed, such as food assistance, public housing, education, workforce development, and health fairs. Now, we are certain that all of these things will reduce unnecessary ER utilization and readmissions. But it's important to still consider the acute care setting because it's a part of the health and social services continuum. And so if our dual eligibles do need acute care, upon their discharge, we're going to make sure they have a comprehensive discharge plan that really works with long-term care facilities as necessary. This will keep our dual eligibles out of this ineffective, inefficient, high-cost cycle going between hospital to long-term care facilities. And it's important to partner with long-term care facilities because point-in-time data consistently shows that 25% of dual eligibles reside in a long-term care facility of some sort. And so to break down some of those access barriers that Amy talked about earlier, our program has specific features. Specifically, we offer extended hours in our patient-centered medical homes, 9 a.m. to 9 p.m. Monday through Friday. We also propose utilizing Mercy's existing ER Fast Track program, which is able to efficiently and affordably care for people who are presenting lower acuity conditions. And so they can go there if they need care outside of our office hours. We also propose using Mercy Health System's existing 24-hour nurse triage line. We've taken the liberty of mapping all of these assets. And it's really important because these assets are already strategically positioned in a 15-mile diameter of where the majority of our dual eligibles reside. We know it's not enough to build a great system and assume dual eligibles will want to come and stay. And that's why we've created a comprehensive membership engagement model which really focuses on recruitment and retention. We focus on traditional media, such as print media, television, radio, and public transportation. We believe that these outlets are the ones that are most conducive to reaching our dual eligibles. We've also provided a sample bumper sticker in your materials. And we augment that traditional media with social media because we know that older persons are the fastest growing adopters of social media nationally. We augment this further by an aggressive community outreach plan in which we put our community health workers out on the ground to get the word out at Parade. Specifically, we'll speak to religious organizations, at town hall meetings, health fairs, and at community events. Our retention model really focuses on increasing medical adherence. And so that's why we offer meal programs to dual eligibles on the days that they have appointments, as well as mileage reimbursement to help defer the cost from getting to and from their appointments. And so we have adopted a total quality management approach to ensuring that our performance is up to par. So what we've done is we've taken the 33 measures that CMS has issued to assess accountable care organizations, and we've distributed them across our balanced scorecard, which is basically a data dashboard. We'll be able to aggregate data using our Press Gainey software. I'm going to talk to you just about how we can measure across three of these dimensions. And so specifically, to measure fair access, we will be able to monitor next available appointment data via our EMR. We'll also measure effective delivery by monitoring readmissions data via our EMR and via our partnership with our MCO, Aetna. We'll also be able to gauge patient and staff satisfaction via surveys. Now to talk a little bit about Parade's financial plan, I introduce my colleague, Amasa Baldwin.
Thank you, Xavier. In creating our financial plan, we decided to align ourselves with the Ohio ICDS financial plan. And we did this because if at the end of this 3-year demonstration, Ohio does decide to adopt this plan, we want to be in a position to effectively handle capitated payments. In doing this, we've created several key assumptions. The first is that based on how the ICDS will assign and enroll patients into either our plan, Aetna, or Buckeye, we expect that we'll have approximately 5,000 patients as our population for the first year, and we will increase this by 10% in the second and third years. Additionally, because Ohio ICDS pays on a rate cell capitated amount, we expect that our capitation payments will be approximately $20,000 per member per year in the first year. And we know that we can save 5% of these costs, which will leave us spending approximately $19,000 per member per year in the first year. This gives us in excess of $1,000 per member per year to share across our partners and our providers. We also know that Ohio Medicaid will withhold 1% in the first year, 2% in the second year, and 3% in the third year of our capitated payments until we hit the quality measures that they have laid out. This will leave us with a total budget of approximately $102 million in the first year to distribute across services for treating our dual eligibles. Now, it's important for us to look at what we're doing currently. And as Amy mentioned, we're spending approximately $42 million in our 4 Northwestern hospitals in treating dual eligibles. Now, over the next 3 years, with the current inflation rate of 4%, this will lead to an increase in costs in treating these patients of approximately $5 million. And even though we have an excess revenue of $2 million, we know that these reimbursements will decrease with CMS's cost-saving initiatives, and that increase in cost will not be sustainable. Now, we believe that Parade will save 5% of the cost of treating the dual eligibles in the 4 Northwestern hospitals. This equates over the next 3 fiscal years to a total cost savings of approximately $18 million. And the way that we will do this in our operating budget is laid out on the slide. We expect to have a total net revenue of approximately $3.62 million in the first year. Now, this consists of our administrative fee that will be paid to us by Aetna of approximately $2 million. This $2 million is 2% of the total expected expenditures on treating dual eligibles in the first year. Additionally, we will have revenues of approximately $20,000, which is our percentage of the withhold that we will receive once we hit those CMS measures. Additionally, we will have approximately $1.5 million in shared savings. Now, our cost for the first year is $3.64 million, and this consists of our total personnel expense, which is those employees that Amy mentioned that we will need to bring on for Parade to be functional. Additionally, we'll have approximately $900,000 in operational expenses. This includes our press scanning software, our patient incentives, and our office leases. And lastly, in the first year, we'll have approximately $1.2 million in startup costs, and that includes our expansion of the Epic EMR and any consultant and lawyers fees we may need. Now, this leaves us with a $20,000 loss in the first year. However, we're confident that with our increase in patient volume and our increase in cost effectiveness in treating these patients, that we will have excess revenues of approximately $1.7 million in the second year and $2.2 million in the third year. Now, in summary, Parade is beneficial for everyone. For our patients, they receive access to high-quality care that is coordinated in a way that is effective and efficient for them. They also have the opportunity to receive patient incentives to increase their medical adherence. For our partners, our local providers, primary care physicians, clinical partnerships, they have an opportunity to receive a proportion of the $12 million in shared savings that we will generate over the next 3 years. But most importantly, for us, for Mercy Health System, we receive $4 million in shared savings over the next 3 years. Additionally, we increase our market share while saving costs. But most importantly, we get to fulfill our mission of providing high-quality care and serving a patient population that is in need. Thank you for your time, and with that, we will take any questions that you all may have.
So how did you select Aetna as your partner over the competitor? What went into that decision?
Pardon me. We chose Aetna because we found a study that shows they have proven outcomes with addressing the needs of dual eligibles. And so specifically, they've been able to reconnect folks to primary care, as well as reduce ER utilization, reduce average length of stay, and also reduce unnecessary readmissions.
And to add to that, they've proven this across 11 different states in the U.S.
And you did mention about partnering with behavioral health centers.
Yes.
How many centers are around there, and how would you establish that type of partnership for 42% of that population?
So for now, we know that although 42% of them have it, we're only going to have 5,000 dual eligibles for the first 3 years of this demonstration. And so we've partnered with 3 of them, and they're on the map, and one of them being Unison, and there's another one called Harbor. And we're going to partner with them through, I guess, advertising cost savings with them, sharing some of that cost savings. So that would be the model behind it. Did I answer the question?
Partially.
Partially.
In terms of your staffing model,
Yes.
could you talk a bit more about the number of community health workers, number of nurse care coordinators that you would have?
Right, so we currently in the staffing model for the first year, we have 4 ER case managers, 4 patient-centered medical home case managers. Those are all RNs. And then for our community health workers, we've laid out approximately 13, and they will work on a zone model, so they will cover different zones in the area of patients.
The FTEs are listed on appendix, what is it?
B.
C.
Good morning. Can you talk a little bit more about, you said on, I don't have a page, page 19, that the best defense against your costs was going to be eliminating unnecessary ER utilization and readmissions. Can you talk a little bit more around your strategy for addressing both of those?
Right, so we're using CMS's discharge plan so when patients present in the ER, we will make sure that our ER case managers work with them and work with the community health workers to really address their issues outside once they leave the ER. The community health workers will even pay visits to their houses to make sure that we set up appointments for them. And that is done with the hope of connecting them to primary care physicians once they leave the ER, so that way we can prevent them from going back to the ER.
And that connection is made how? How is the ER case manager going to get the information to the community caseworker?
Through our EMR Epic.
I want to go back to your staffing model, please. And based on what data did you put together your numbers for your salaries?
The Bureau of Labor Statistics.
Okay, so the average caseworker, community health worker is paid in the $30,000 range?
Correct, because we are assuming that they're going to have at least a high school diploma.
Okay. And what are your assumptions around the executive director?
The executive
director?
It will be a physician executive director because we looked at NCQA's best practices, and it should be a physician-led initiative.
Okay.
So related to that, I noticed that your costs for the parade program actually go down after year 1.
Yes.
Why would you anticipate a reduction in costs when you have more membership?
Right. The reduction in cost is essentially no longer having to pay for the startup costs.
But your staff, you're presumably going to give them raises, right? And eventually need more FTEs to cover.
Yes. In the 3rd year, we do increase our FTEs from 26 to 28, I believe.
And what about the parade expenses? I didn't see something that summarized what those were.
It's in Appendix F, I believe.
Okay. Thank you.
You're welcome.
And could you say a little bit more about in terms of the savings associated with reductions in the ER utilization and admissions, readmissions? Do you have any calculations, relationship of the rates of utilization going down? Did you do any analysis to come up with the actual dollar savings?
Right.
The actual statement.
Right. So we looked at market research on cost savings in terms of coordinated care models, and we found consistently across the board that it's a 5% cost savings.
Right.
Okay. So you did it more on a global basis versus looking at
Ohio.
Right.
Yes.
each element.
Correct.
I have a question, and maybe you covered it, so I'm a little confused. I was looking at your organizational structure, and you're referring to a coordinated care model with a coordinator or community coordinator, or
Community health workers, and then we have ER case managers.
Right.
community health workers.
Right.
So each individual community health worker will be responsible for coordinating care throughout the Northwest Ohio system and connecting the dots with the patients and the providers.
So in terms of that relationship, we have 2 key staff members, and those are the nurse case managers and the community health workers. The nurse case managers work within the facilities to ensure that a care plan is accurately created and then properly executed.
Okay.
The community health workers are more like our foot soldiers. They work with each dual eligible to make sure that they're getting to their appointments correctly, that they have their medication, that they filled out all the correct forms. And so one really coordinates care in that clinical setting, and then one is on the ground in the community to make sure that the dual eligibles are adhering.
Okay, if I may ask just one more question. So how are these members and the dual eligibles are going to be aware of this type of care that you're going to be producing and selling? How are you going to sell it to those members to be utilizers of it?
Well, according to the ICDS, these members are going to be placed into either Buckeye or Aetna. And so when they become part of Aetna, which we're assuming 5,000, we will send them not emails, but letters and advertisement and actually explaining what Parade does. And also, we will have pamphlets and marketing materials at the Ohio Jobs and Family Services. So if someone needs to go there to become part of Medicaid, the person working will actually hand out the information to them. So that's how they will start to learn about it, in addition to newspaper flyers and just regular letters.
And you have your marketing costs baked in here as well?
Yes, it's appendix, I believe, I.
So what's the incentive for the social services and the behavioral health services to work with you?
So with the shared savings, we would divide that up amongst all of our partners. So we expect a 12 million shared savings within the 3-year period.
Right.
Right.
And then proportionately to risk, we share that amongst our partners.
Correct.
So you said proportionally according to risk. What's the risk? What's the sharing model?
So because Parade and Mercy Health will assume the highest amount of risk, Parade will get 30% of shared savings, Mercy Health will get 20%, and then we go into primary care physicians, behavioral health, and long-term care.
So they had to pay into?
No, they didn't have to pay into it.
No.
So your connection with the primary care physicians is through the care coordinators you're placing in their office, and then through this incentive model? That's what gets them engaged?
Yes, that's correct.
Just to clarify, did you determine that you had, so when you're starting the 2 new PCMH homes, where are the primary care providers coming from?
They're coming from our existing assets in Mercy Health System. And so we've chosen to use our existing assets because the ICDS demonstration begins in less than 6 months in April of 2013. And so we've chosen to use our existing assets because they're a lot easier to align ourselves than it is to try to build something new.
Right. And we really want to pull physicians from each of the 4 hospitals because we feel like we need to have a physician champion in each one of these hospitals that understands the delicate population and how important catering to these individuals are. And with these physician champions, they can kind of they can have people gravitate toward them for the common cause.
So is it really true that seniors are the fastest adopters of social network?
Yes, it really is.
Wow, that's news to me.
It's free.
On your shared savings approach, are the long-term care facilities included? You mentioned 25% of the population would be in long-term care. Are they part of the shared savings model?
Yes, they are, absolutely, yes.
Do you have that? Is that in one of the appendixes?
Yes, it should be in the same appendix that shows the operational budget. It shows the way the shared savings will be distributed as well.
Thank you.
You're welcome.
All right.